Good afternoon, everyone. So I'll be discussing on when, why, how a perfect RD surgery should be done. A brief background: glaucoma, one of the leading cause of irreversible blindness, with the prevalence in India being 2.2 to 5.8%. And of course, TRAP still remains the primary surgery of choice. And we have to accept GDD also plays a major role in managing refractory glaucomas where primary TRAP is going to fail. And of late, this GDD is also being used as a primary procedure too. In certain conditions like NVG, post-PKP glaucoma, glaucoma second to VR surgery, refractory infantile glaucoma, un-AD associated glaucoma, and glaucoma associated with SPS, aphakia, pseudophakia, eye syndrome, uveitic and traumatic glaucoma. And over a period of 13 years, there have been a lot of surgical refinements have been made in the RD surgical technique to decrease the complication rate. And going back to the timeline, the first RD surgery was performed in 2011, and it was made commercially available in the market in 2013. And until 2016, in our institute, we are performing RD with patch graft. From 2016, we slowly shifted to patchless RD surgery. And from 2021, we started the technique of intraluminal stenting of the RD tube. That is using a 3O nylon multifilament suture. So which I'll be showing the subsequent session. I'll be sharing few tips how a perfect RD surgery should be done. This I'll be discussing under 3 headings: preoperative care, intraoperative steps, and postoperative care. So I would like to emphasize here that preoperative planning before we take up any patient for RD implantation, it's very, very important. I'll be sharing few clinical scenarios where preoperative planning is very, very important. So this patient, as you could clearly see, is a case of golden hour syndrome. You could see preauricular tags with a limbal dermoid in the right eye. And he had a microspirophakia with secondary angle closure glaucoma. So with the advanced glaucomatous damage and high intraocular pressure. So we planned for a sequential quadruple technique, that is PPV, PPL, SFIL with RD implantation. First in the left eye, it was uneventful, but in the right eye, we had a difficulty since the limbal dermoid was sitting here. We had a difficulty of conjugal dissection and the retinal port incision and everything. Hence, initially, we performed a limbal dermoid excision and subsequently we proceeded with the quadruple technique. And next, in few cases like eye syndrome. So this patient, a case of essential iris atrophy with significant cataract and advanced glaucomatous damage. So in such cases, we have to assess a proper cornea endothelium status before taking up a patient for surgery. So this patient, we planned for a combined phaco with the RD implantation. So this patient, we did a supero-nasal phaco along with the supero-temporal RD implantation. And in few cases, assessment of anterior segment, that morning I was showing, the child had a multiple anterior segment pass. So almost in the superior quadrant, the child had a secondary angle closure glaucoma. So we did a modified tube entry. So for this, we did a gonioscopy, we did a ASOCT assessment also to assess the area which was free of pass. But since the child had significant pass in the superior quadrant, we planned for a modified tube entry, which is nothing but introduce the tube into the sulcus and via the surgical aerotomy, taking the tube into the anterior chamber. And in few cases, so this child I was discussing in the morning. So this child, initially we proceeded with the trapless trap in the left eye and trabeculotomy in the right eye. However, a trapless trap failed in the left eye. Then we proceeded with the non-walled RD implantation. So here the child, when we did the B scan, so the B scan showed significant increased retinal choroidal thickness, and hence we proceeded with the prophylactic sclerostomy and then we proceeded with the non-walled RD implantation. So these cases I just shared to emphasize how a pre-operative planning is very, very important to avoid unexpected complications in the post-operative period. Now moving on to intraoperative tips, I'll be sharing a step-wise video of how a perfect RD surgery should be done. First and foremost is conjunctival traction suture. So this patient, a case of PECG with a post-failed trap. So he had a refractory glaucoma. Hence, we planned for a superotemporal RD implantation. First, I'm taking a corneal traction suture with a 7 silk. And then a 3 clockers of conjugal peritomy is made along with the adequate T-nonce dissection. So this T-nonce dissection and limit of conjugal peritomy is very, very important for the adequate placement of the RD device. since the surface area of the Aadi is 350 mm square. And next, we have to exactly at the midway between 12 and 3, we have to introduce the muscle hook. This is the place where you enter, you will get the exact location, you will get the superior rectus and the lateral rectus muscle. A gentle lateral traction is created to create adequate space. And then a muscle, beneath the muscle, we have to introduce a second muscle hook to create some space for the lateral wing of the Aadi plate to sit in smoothly without any resistance. So you could see adequate space is created. So if adequate space is not created, then we will have difficulty while inserting the lateral wing of the Aadi plate beneath the muscles. And this is a Aadi implantation. You could see the drainage holes and the fixation holes. First, the Aadi tube patency is cross-checked with the saline irrigated with 27 gauge needle. So this is the intraluminal ripcord stenting with 3-0 nylon multifilament suture. Just 1 to 2 mm is introduced into the tube. And we usually practice the technique of double watertight occlusion suture. No saline should be flowing through the tube. So complete watertight tube occlusion is cross-checked by irrigating saline. You could see the saline reflexing from out of the tube. Now, this external tube occlusion is achieved with the 6-0 vicryl suture. And once the first occlusion suture is done, now the Aadi plate is introduced beneath the superior rectus muscle first. So this right angle bending of the tube, it's a clear indication that the Aadi plate is entered beneath the muscle. And then the lateral plate is also placed beneath the lateral rectus muscle. So once it is placed, gently do a gentle movement to make sure that it is not struck in between the muscle fibers. Now a partial thickness 3-notch traction suture is taken with a 7-0 silk for adequate exposure. The plate is fixed to the sclera using a 9-0 nylon non-absorbable suture. This is to prevent the posterior migration of the plate. Suture knots are always brought into the fixation hole to avoid suture-related irritation in the post-op period. The other end of the plate is also secured to the sclera. And now the tube fixation is done using a 9-0 nylon non-absorbable suture. So this is to prevent the lateral movement of the tube. So once this is done, a second watertight tube occlusion suture is placed. It should be placed just in front of the supralon stenting. So one occlusion should be over the supralon, another should be anterior to the supralon suture. So kindly make sure that all the suture knots are towards the side of the tube. It should not be over the tube or it should not be under the tube. So this might lead to unnecessary conjunctival irritation and erosion can occur, and either a tube exposure or the suture exposure can happen in the immediate post-operative period. So this is a clinical image of a patient where you could clearly see the plate is just sitting in superiorly. This was referred from a nearby center. So here you could see the plate was sitting in superiorly. It was not in the superior temporal or superior nasal, which means the plate is not been placed in a proper position. So it has migrated anteriorly. And here, almost as I mentioned, the suture is placed over the tube. So this has eroded the conjunctiva and this has led to conjunctival erosion with the tube exposure at 4 weeks post-operatively along with the discharge. And this is a dynamic tube movement. So if the plate is not fixed, secured properly to the sclera, then with each extraocular movements, the tube can just go in beneath the pupil and come out of the pupil, just rubbing the pupil. So such dynamic movements could happen if the plate is not secured well to the sclera. So now comes the most crucial step, that is the creation of 4 mm long scleral tunnel. So here the tip of the bevel is 2.8 to 3 mm. This is the 23 gauge bent needle. So this 23 gauge bent needle is used to create a 4 mm long scleral tunnel. So in our institute, we are routinely we are doing a patchless Aadi surgery, but placing a patch graft or patchless surgery depends upon the surgeon's discretion. So since this is a patchless surgery, this 4 mm long tunnel is very, very important to serve the purpose of graft. Here the main aim is we are aiming to place the tube within the patient's own sclera. That is, the partial thickness of sclera should be covering the tube. So this will avoid the tube exposure in the post-operative period. A 4 mm mark is made from the limbus and 2 mm medial to the limbus is made. So the meeting point of 4 mm and 2 mm, you have to create a small groove. And bent 23 gauge needle is taken and exactly at 1 to 1.5 mm from the limbus, the needle is bent into the anterior chamber. All the movements should be very gentle. There should not be any sudden decompression of the globe. Always aim to place the tube towards the iris tissue. Stay away from the corneal endothelium as possible. While taking the tube out also, you should be very gentle. And now the tube is draped over the cornea. 2 mm mark is placed on the tube since we are aiming to place the tube in the anterior chamber. A good bevel up is created with vena scissors. Now the tube is introduced into the tunnel. So always try to use non-toothed instruments. Avoid using any toothed instruments while handling the tube. The tube is gently guided. This sinuous course will prevent the tube exposure in the postoperative period. Otherwise, we will have some extra length of the tube whenever we are planning for resurgery in case of tube retraction. Just I'm cross-checking that the anterior ridge of the plate is 10 mm from the limbus. So few cases when you're going to notice the pass at the indented tube entry site. As I already mentioned, we can make a modified tube entry also, like a small surgical iridectomy can be created, and then the tube can be introduced into the sulcus, and through the sulcus, the tube can be brought into the anterior chamber. And next, the supramid's placement in the subtenon space. A small tunnel is created, a small tract is created in the subtenon's area, and the supramid suture of adequate length is cut and it is placed in the subtenon space. So this supralon suture, it should be planned for removal only after 6 weeks after autolysis of the tube occlusion suture, that is after 6 weeks. Only if the IOP is going to be high. Otherwise, the suture will stay as such. Even for several years, it might be left as such. Finally, the conjunctiva along with the Tenon's tissue is covered. And here you could see the adequate length of the tube in the anterior chamber is 1.5 to 2 mm. And the postoperative care, if you're going to notice a high intraocular pressure after 6 weeks, then we may plan for supramid suture removal. This should be done under strict aseptic precautions. So just a conjunctiva and Tenon's tissue is dissected and the supralon suture can be pulled out. We must take care that there should not be any shallowing of anterior chamber and there should not be any hypotonic. So we should carefully monitor the patient after the supramid suture removal. And this is regarding Aadi 250. So Aadi 250, it is just a surface area of the Aadi implant is 250 mm square. And it can be recommended in cases where we were planning for a superinasal repeat Aadi surgery. And in uveitic and neovascular glaucoma, where the chance of hypotony is going to be high, and cases with microphthalmos, narrow palpebral aperture, and patients with extensive congenital fibrosis following multiple VR surgery. The steps are exactly same. Only thing is, here the lateral wing will not be that much long, so it will be easy for you to place the implant beneath the muscles. Other steps are exactly the same. The 4 mm mark is made and the tube entry is done. So here are some reference papers which we did in our institute. So we just did a retrospective analysis of Aadi implantation with and without patch strap. As I already mentioned that until 2016, we were doing all Aadi surgeries with patch strap, and from 2016, we slowly shift on to patchless Aadi surgery. So we just analyzed the outcomes of 215 adult eyes and 111 pediatric eyes, and we found that the patients without patch strap, there was no any tube exposure, and with patch strap, in adult eyes, we had only 2 eyes, and in pediatric eyes, we had 5 eyes. So hence, we concluded that patchless Aadi surgery is equally safety in doing in patients with refractory glaucoma also. And this is a study which we did on neovascular glaucoma patients. And here also neovascular glaucoma, although the initial stages was little bit IOP spike, but later on we found only 30% failure rate at 2 years. And in refractory glaucoma also, there was a significant decrease in intraocular pressure until 48 months follow. Thank you all for the patient listening.